it's always advisable to have at least 3 calendar sizes. Your sizes you think you will use, one below or one above, and have a strategy for conversion if need be. And also have an idea of what are the possible concerns you might be dealing with when you get into the chest. For me, exposure is very key. If you don't expose properly, you run into difficulties, you struggle, and once you're struggling, that's where you have complications. So expose properly. If you're going to let the ascending aorta, expose the pericardium nicely, expose the aorta, ensure you dissect within the ascending aorta and the PA, because eventually you need the cross clamp to go in this space here. So you don't really want this, as the diagram shows here, where you have a space below the aorta. You want the cross clamp to go all the way down. And to achieve this, you need to dissect in this space. Some of us use tapes. I like using tapes if I'm doing coronaries because it helps to lift the heart, the aorta upwards, while you can put your cross clamp quite nicely down on the aorta to avoid any gaps. Next thing is you expose also for your atrial cannulation. Make sure you can see your atrium. If you're going to do just a simple coronary case of the valve, aortic valve, all you need is just the appendage here. So if you clear the appendage nicely, fine. If you're doing the bicaval cannulation, if you expose the SVC, which will be up here, and the IVC, which will be down here, see it nicely, you know you have it under control. Now, when you're trying to achieve this exposure, you could have injury to the aorta. So you have injury to the back of the aorta or the side of the aorta or the PA. Any injury you have at this stage, because at this stage you possibly may have given heparin already. Your finger is very good. Just put your finger on the spot, get some big swabs, pack the area, no panic, everything under control. Now progress, inform the team that you have this bleeding, everyone is aware, everyone is ready, ACT has been got done, start putting your pulse strings for or for bypass, and just plan to go on bypass as quickly as possible. Once you're on bypass, everything's under control. And now you can look at the injury you've had and everyone advised to repair under direct vision. Do not just take stitches everywhere. You cause more problems than you're trying to solve. So depend on direct vision. And when you're repairing tissues like the atrium or the cava, you need to be mindful to always have a tension-free repair. If the tissues are very stretched, you might need a patch to augment your repair. Otherwise, even if you repair it, once the heart is full, because of the tension, your stitches pulls away, and you have a lot of bleeding afterwards. Once you're happy, you're happy with the exposure, and you think you're happy. Next thing, give heparin. Now, heparin is obviously just give the adequate dose for the patient. There's always a dictum of 300 units per kg. And give heparin, send for ACT. ACT comes back 480 or whatever you think is probably for your center, but most people use 480. Good for bypass, fine. At that time, you're already putting your stitches. I tend to personally not be in a hurry at this stage, send for the ACT, because at this stage, you can still back out from surgery. So send for ACT. ACT is rising nicely above 400. You feel comfortable, you put your stitches. But sometimes you give heparin and ACT is 200. Oh, why is this? And that's possible heparin resistance. And it shows from studies like what Chen and Tal described in 2022 that it looks like it's not very common complications, but it could be up to 22%. So 1 in 4 patients or 1 in 5 come for surgery will have heparin resistance. You can anticipate it. So there are patients from the history I would suggest they could have this complication. People have had previous cardiac surgery, in vasectomized in men or diabetics who are already exposed to heparin from their medication. They could have this risk of heparin resistance. The first thing you do is think about, okay, am I giving appropriate dose? You think like silly things like your heparin is expired. You're surprised. You look at heparin, oh, it's a different brand. So last week you had surgery, no problem. This week you're having surgery, you're having heparin resistance. Why? It's possible within the week you've changed the brand of heparin you use and possibly using a different quality of heparin. So if you think that's the problem, give more heparin. So give a solid heparin, wait, do an ACT. If ACT comes back just by giving extra dose of heparin and ACT is not still in range, then you think of heparin resistance possibly to antithrombin 3. So next thing, you give FFPs. This is easier to have on the shelf than in trombin 3 in most centers for me. This is easier. So you can give FFPs, which will provide trombin to the system that the heparin can bind to, and you can help the ACT to be in range. And if that doesn't work, then you can go to antithrombin 3. It's always advisable at this point to involve your hematologist because they can also guide you in information about what you can use and support you in providing these medications, which will not be on shelf every time in one's institution. If you've had a history of a patient who's already have heparin resistance in the past, then you can look at alternatives. I would advise using alternatives on the same day of surgery when you don't have planned for this, because these alternatives are not, you don't use them routinely. You may have forgotten the protocol, how to use them. So it's there in the literature. I've seen it's been used before, but it's when you plan. So you can use the direct trombin inhibitors like bivalirudin and agrabatan, and that can help you go on bypass. The sad thing with them that there are no reversal agents. So if you just use them and you do surgery, you have to wait for the half-life to wear off and patient stop bleeding before you can leave theater or close the chest. Don't be shy to abandon. It's not a failure of surgeon. If you go in theater, get heparin resistance, give heparin, no response, get FFP, no response, antithrombin, no response, you can't abandon the procedure or change your strategy. I had, I think a few months ago, a patient coming for acute patient, it's NSTEMI, coming for coronary bypass graft. We did everything. HCCT was still about 300, even after giving heparin, FFPs, and trombin. And what did we do? We couldn't, in that tree bypass, we did an off-pump limal to LAD, and we sent him for a hybrid stenting of his remaining coronary vessels. So don't be shy to abandon the procedure if it's not safe to proceed. Once you have ACTs, fine essence correlations. And at this, for me, this is where I relax, I concentrate, and be systematic. I see most of my registrars at this point, they're in a hurry to get it done so you can get done and do the case itself. Uh, just relax. There's so much time. You think you're in a hurry, but you're not getting time when you have complications. So relax, palpate the aorta, feel it. Make sure there's no plaques, and make sure there are no excessive calcifications. If there are, you don't need to abandon surgery. All you need to do is to place your cannula in the right spot that is soft and there's no calcification. Look also where you put a cross clamp. Is there soft area for a cross clamp? If there is, then you feel safe to proceed. You also know that you have a higher risk of having a stroke in such patients with calcifications in the aorta. The pulse strings. So when you palpate the aorta, it gives you an idea also the thickness of the aorta. Some aorta are very thin and friable, especially in elderly patients. These are the ones that will be a nightmare when you're placing a pulse string, where you have multiple holes that are bleeding and you just be a mess. So that guides you how you to place your pulse strings and place the pulse strings. They're going not transmural, they're going to the media. So gently, nicely place pulse strings, diamond shape I commonly use, and plan to cannulate. When you're putting your cannula through, you should slide without resistance. Once you have resistance, there's a problem. Either it's too small a hole, or you are in a wrong spot where there's calcium, or your cannula is not well handled. So also you have to understand what cannula am I using. You must see it before handed to you on theater. Understand its way you to maneuver the cannula into the patients, and always seek your support of assistance if you need some assistance during the procedure itself. And for venous cannulation, quickly, I'll just say beware of the fibroatrium. Once you can see blood cells flowing to the atrium sometimes, this is fibril. You have to be very gentle. You have to understand if you're going to use single stage or bicaval cannulation for the surgery. And you understand if you're doing bicaval cannulation, the tip, the tip must go into the IVC and the other bit in the RA, so you can drain both parts of the atrium. And always think about alternative cannulation strategies if you find, oh, this will not be appropriate. You find calcium on the aorta, you can go to the femoral artery and cannulate, or the axillary if that's appropriate for you to do. So I want to understand your cannulas. So these are different size cannulas types. There's so much on the shelf. Know what you have in your shelf and how to use them. I commonly prefer the one on the right, the Medtronic Iopa cannula, because it has a stillet there inside, and you see you can almost be like doing a Sardinia technique to put this in. So this tip here, just guide slice quietly into the aorta and let the cannula itself glide through. These are some venous cannulas. This is a two-stage cannula. This is a three-stage cannula. This is a single-stage cannula. These are the curved tapes. If you're doing bicava cannulation, I personally use the curved tape cannula for the SBC and a straight malleable for the IVC. And you have to understand, discuss with your perfusion to know what size of cannulas he will require to achieve adequate perfusion of the patient and also adequate drainage of the patient. So with discussion with perfusion, you ask him what size do you think you need for the bypass of this patient based on his BSA weight and height. And if he says, oh, I think I need 34, look at the heart and see if it's good enough to put 34 and you deliver that. If you put too small, he has poor drainage and he struggles, and then in the surgery, you had distending not getting well emptied. So you need to discuss properly with your perfusion at this stage to size your cannulas. So let's show this a bit. These are a few pictures on the condition strategy. So here you can see there's a pore string. This gentleman is using a Prolin pore string. I commonly use Tricon, and it's got the adventitia of the area onto cannulates. It's made a small cut in the aorta prior to cannulation. I don't really do this, but if that's something you learned, that's fine. I tend to hold the adventitia here, so that controls. You can see there, you can control closing up this hole once you made a stab in the aorta. And when you're stabbing, you're not stabbing at 90 degrees, you're stabbing at like 45 degrees. So it's gentle slide into the aorta and out to avoid hitting the back wall. But you can see also here the exposure. You can see the space between the aorta and the pulmonary artery is exposed there quite nicely. And here you can see the other side. So you have both have the aorta available to you. And I'll just want to show my cursor here. This is a cannula for the aorta. You say it's facing downwards. That's a style for this cannula. You face downwards, insert it, and you turn around, turn it over 180 degrees to face the arch of the aorta. And this arrow down here, you can see this adventitia tissues that holds the SVC to the pleura, to the pericardium. If you divide these reflections, the SVC comes nicely and long, and you see a lot of space to put your pore string and to cannulate. So if you're going to the mitral valve or you're doing bicava cannulation, this is a good move to do to get your good exposure of the SVC. Once you cannulate, you de-air your cannula and different techniques. Put a small swab, or clamp and release, put in a pot, drain it back to the patient. And sometimes you see this, and this is a disaster. You don't want to see this. This is an effect of poor communication. Poor communication. Communication on table is always a two-way communication. So heparin, and you get a response. Heparin given. ACT, you get a response. ACT is back, and you must get a response from your perfusion and your team. It's a two-way. So when you request something, you get a response. So this is obviously the ACT is not in range, and you have the blood is just clotting off. When you have this SAD, you have a risk of having a stroke. Fine, clamp the aorta, check your ACT again. You might need to put a new pipe in, so this will come out and get a new pipe. And once your ACT is fine, you put a new cannula to the patient. The cannula, you don't cannula to be here exactly, it would be in the lumen, just halfway in the lumen. When the cannula is just in the wall of the aorta, this is where you had the risk of having a dissection, because when you go on bypass and the flow here going very as high as 200 meters of mercury, it could just raise the flaps within the layer of the aorta, and you have the dissection going through. If your cannula is too deep, you hit the back wall, and once you go on bypass or you start to flow, your perfusion complains that pressure is going too high, pressure is going too high. Why? Not because the cannula is hitting the back wall. You can manage this easily, flow down, release the cannula, pull it backwards a bit, and ask for its response. And once it has a good pressure, you can carry on with the procedure itself. This is also a description of the right atrial cannula two-stage different holes. So people wonder why you do aortic cannulation before venous cannulation. One thing quickly I'll just say is arrhythmias. Once from atria are very arrhythmogenic. Once you touch the atrium, you get arrhythmias, and that can affect cardiac output. As we know, when you have atrial fibrillation or arrhythmias, you lose 25% of the cardiac output due to the loss of atrial kick. So preferably for most people, do the aortic cannulation first, so you have the aortic pipe to give volume if need be before you touch the atrium. Once you touch the atrium, get the atrium, and if you have someone who has severe aortic stenosis with a very thick ventricle, they really like the atrial kick. And when they lose that, you have decomposition on table and everyone begins to panic. So the main thing about cardiology is about control. If your cannula is well placed, you have good drainage. If it's not well placed, you have inadequate drainage, and the heart just gets big, distends during the case, and your perfusion will always be alerting you, and you struggle during the case. So make sure your cannula is in the right place and getting right drainage. If you have atrial tears or caval tears, you want to avoid this by being very gentle with tissues. If they happen, extra stitch can help around the cannula most time when it occurs. And if it's a large tear in the cava or something that's bleeding quite massively, fine. Put your cannula into the SVC, into an IVC, bicaval cannulation, go on bypass, ensure your perfusion understand there's a tear so you don't suck with so much suction and get air into the pipe, and now you can repair the cava under direct vision. So once you already have having bleeding around your pipes or there's cable tears, you have the risk of air embolization. So we communicate to perfusionists, they put the flow quite slow. They'll never be on full flow. Patient heart is still beating, it's not arrested yet. So the patient is still pumping blood around its own body. Then once you go on bypass, low flows, you can make sure you don't have air embolism and repair the tear that can lead to this. This can happen when you have a declination on table while doing the surgery. It's possibly due to your a loose ball string or a loose tie on the tube itself. So always be aware that people should just be mindful how they move their hands or instruments around the table, to always do things with vision. Always see what you're doing before you do it. Once you're on bypass and you're cross clamped, you're happy with the cross clamp, necessity myocardial protection. First, you need to understand your solution you're using. So if you know what your solution you use, then yes, carry on and use it. So for us, I commonly use St. Thomas, which always repeats every 20 minutes, 15, 20 minutes. If you think you go to a center to do surgery and they use Donlido or they use St. Thomas and you think it's Donlido you're using or Custodio, and at 20 minutes you don't replace cardioplegia, you have my heart is gone. So you need to understand the solution you use so you can communicate properly with your perfusion and use the right solution and understand the timing for that solution. You need to understand how you deliver your cardioplegia. Are you going to go antegrade alone, antegrade and retrograde, or antegrade or retrograde alone? So understand when to use each and use it appropriately. People always fear to use retrograde, which is true, because you have to make sure the pressure you're giving to the coronary sinus is not too great. Never go above 50, so stay within 30 and 50, but you have to communicate properly with your perfusion and your anesthetist who is monitoring the pressures in the top to make sure he's giving you the right pressure and the right tracing when you're giving the cardioplegia. You have to decide what temperature for the case you're going to use. Is it going to be normothermic or hypothermic? And ensure that you're giving the right, you are managing that temperature appropriately. You don't want to, if you want to cool the patient and specify temperature you're cooling to in every case. One common thing is LV distension. Once you're giving some blood in the heart, or the heart is fibrillating or arresting, you can have LV distension from blood coming to the heart and not draining properly. People tend to use vents, the different ways you can place a vent, and there's most of the complications you get doing this procedure is when they're doing venting. You're doing a valve case compared to the PA, like you're doing a aortic valve, but you have to be careful when you're uh, venting the PA, not to perforate the back of the PA, or not to just put your vent too far in and only drain one side of the PA. So make sure your vent is well placed and be gentle when you're inserting your vent. If you're using the reciprocal vent, it has a stillet as it goes in. We all know that once you get through when you're in the atrium, you're getting to the mitral valve, you're pulling your stillet out and you're pushing the cannula in. You have to be careful. I've seen cannulas perforate the LV and come out from the back of the heart. So you always be careful about that, not to perforate the ventricle. If that happens, fine, you can repair it with some platelets after the procedure. Topical cooling is quite controversial these days. I personally don't use it. People do it. It's a thing of antidote for what we used from the past. Topical cooling on the heart helps to improve myocardial protection, but we have to be aware of penicillin injury. So people don't use sometimes just cold saline. Some people still use ice slush. Let's say a best evidence paper by Alasai et al. 2014. I think people should read it. It did suggests that based on the randomized control trials that have been performed around the world, they did not find any real benefits using topical cooling. But I think people who use it will not change their habits. So it's fine to use, but just be wary of chronic nerve injury, which sometimes is just neopraxia, but sometimes can persist. And just imagine having neopraxia after surgery, left the diaphragm is up, affects your respiration. The patient struggles in ICU. So those are things we need to be aware of when we're doing these procedures. So I'll quickly go to some scenarios which I think might be important to us. The first one is, which for me I think is common, is you go on bypass. After 5 minutes, patient tells you, "Oh, I'm not getting enough flow. I'm not getting enough flow. Is there bleeding anywhere?" Keep complaining to you. And in doing surgery, which is say you're doing cardiac surgery, you're under a bit of pressure, and your hand is coming from perfusion. It's quite distracting and can put you under a lot of pressure. The first thing is intravascular volume. So when your anesthetic is putting the patient on, putting lines in, try to just walk into theater and just see what the CVP is. It gives you an idea what the starting CVP was. So if someone comes in theater and CVP is negative or zero, obviously this patient is intravascular dry. When you go on bypass, they will struggle because there's no lot of volume in the patient. So you're meant to give more volume in such patient on the pump. So you could educate your perfusion. So okay, just add some volume on the pump, get some blood, and that will just improve the intravascular volume or the pump volume, and everything goes fine. The next common thing is cannula problems. Your cannula properly placed. So ensure your cannula is placed in the right place. So when they complain, take some action, adjust the cannula, and most times just little adjustment of the cannulas, especially the venous cannula, your perfusion is happy, and you can carry on with your procedure. Airlock is something you read in the books. It's not really very as common as, but it happens where air going into your circuit and just blocks the whole circuit. As I say, these things will not happen if you have good communication, because if you don't see the surgeon, your assistant watcher says, "Oh, there's some blood, there's some air in the pump," and you saw it out before it becomes a large airlock, or your patient sees some air coming down and tells you, "I'm getting some air in my pump," and you quickly intervene before it becomes an airlock. So these are better prevented than when it happens. If it happens, fine. Depends on the stage of the surgery you are in. If the cross clamped and the heart is still beating, all you can do is just to reduce your flow, start ventilating the patient from the anesthetic side, uh, clamp your venous line and your cannula, take it off together, fill up your line, ensure fill up your line with fluids. It drains into the reservoir, and you connect and commence bypass. It takes you just be less than a minute to get this done, and you're back again on full flow. What you don't want to say is aortic dissection that causes you CPP flow, because once you have dissection in the aorta, that's where you don't want to happen, because it's bad for the patient, because it's a lot of mobility and mortality. The patient that has dissection on table, and I'll discuss that later. What you do when you have that. You can have a bit of thrombus in your oxygenator, and if your ACT is not being monitored properly.
Ben, you have to round up. You have to
Okay.
round up.
All right. I'm almost okay. You can have a thrombus on the oxygenator, and you can just make sure your ACT is under control. Um, Quickly, just to go to this, if you have oxidation is poor, look at hematocrit, check oxygenator, and also increase oxygen supply. Massive embolism is not very common, but if it happens, there are steps to how to manage this, which I can provide the slides for you guys later. If you dissect on table, you first thing you see is increasing arterial line pressure. How do you identify this? If you have a TO on table, you can see the dissection flap. The main thing is to change your cannulation site and cool the patient down and plan to repair the aorta. When this occurs, if you have any pump failure, arterial failure, the main thing is to have a plan by your team, which you do maybe every once in 4 months, a dry run for this kind of procedures, how to change your pump quickly. So in these conditions, you need to change your pump and go to make patients safe. Severe hypothermia reaction is quite, yeah, I've seen a bit of it now. And the main thing is how do you to rest the right ventricle and reduce the pulmonary pressures on the bypass. First thing, to anticipate this kind of patients. So always, the patients who have vasculitis can have this, and prepare for that. Give oxygen 100%, vasoconstrictors, bronchodilators, and sometimes you might have to give this medication like meroinone, estopiroline into the PA itself to reduce pulmonary pressures. So in conclusion, quickly, just to say that if you want to reduce complication from bypass surgery, you need to plan properly to understand these complications, be prepared to manage them, and communicate effectively. Thank you.
Thank you, Dr. Ben Omaragwe, for your presentation. So now I call on the next presenter, a homeboy by name Dr. Saeed Daudu. He will be talking to us on pacemaker insertion. By the way, that's lecture 3. Lecture 3. Thank you.
Good morning, everyone. Good morning, everyone. We'll be discussing pacemaker implantation. Discussing pacemaker implantation. Next slide, please. It's outline. I hope everyone can hear me, and the audience on Zoom. So I'll be using this outline, just a bit of historical perspective and then indication. So I'm going to focus mostly on the permanent pacemaker insertion. This is just a bit of historical perspective, how we got from the picture on my left to the picture on my right. This picture was that of the initial pacemakers that were used, and then this is what we have now with the picture on my right. So just briefly, Paul Zoe was the first person to do a transcutaneous electronic pacemaker in 1952. And then in 1958, temporary endocardial approach was developed by Simon Foreman. The picture that we saw, the picture that was on my left with the big, that was Simon Foreman's pacemaker in 1958. But the first definitive electronic pacemaker was implanted in October 1958 by Senin on this patient, Anne Larsen, who was the first patient that got a pacemaker implanted, a permanent pacemaker implanted. Unfortunately, that pacemaker lasted only 3 hours and stopped firing, so it had to be changed the following day. And that patient was actually in the hospital for several months, had several pacemaker changes, but he survived, did well, and eventually died in 2001 at the age of 86. He had more than 22 replacements in his lifetime. In fact, he was said to have outlived the surgeon that implanted the pacemaker, which is a good thing. But anyway, over time, there's been numerous improvements in the pacemaker, obviously, from the size and everything, all down to what we have today. But one of the notable improvements that have occurred, it's in the battery type, from where it was started with nickel cadmium batteries to where we are now, lithium iodide battery cells, which have the almost perfect qualities of what one would want in a pacemaker, which is an energy dense, small volume battery. So I'll go on to the indications. Now, the main aim of pacemaker therapy is to alleviate symptoms and prevent subsequent morbidity and mortality from bradycardia. So bradycardia of various causes. Now, these are the main causes and the main indications: sinus node dysfunction or the sinus bradycardia from drug therapy that is actually indicated. Third degree heart block or advanced second degree heart block, which is symptomatic, or chronic biotrifascular block, symptomatic sinus bradycardia or sinus pauses, hypersensitive carotid sinus syndrome, and atrial fibrillation with slow ventricular response. These are class 1 indications for permanent pacemaker insertion. Now, the main contraindication to inserting a permanent pacemaker is the presence of an active infection, which should by all means be treated first before a permanent pacemaker is inserted. I mean, if the need for it is urgent, then a temporary transvenous or epicardial pacemaker is used as a bridge. Now, just look at some basic concepts. What the pacemaker is made up of: the pulse generator, which has all these components as shown in the picture. The pacemaker leads, there are different types of pacemaker leads. The most commonly used, obviously, especially in the adult population, is the endocardial lead, which is put transvenously. Then in the pediatric population, epicardial leads are commonly used, especially in children under the age of 5 years. The leads may be unipolar or bipolar. It may be active or passive leads. These pictures just show a passive lead and an active lead. There are some basic concepts. The pacing, which essentially is timed introduction of electrical impulse leading to depolarization of the surrounding myocardium and propagation of an active wavefront. So capture indicates that there's successful pacing. The pacing threshold is the minimum energy required for successful pacing. And then sensing is the feature which enables the pacemaker coordinate pacing with the intrinsic electrical activity. So the nomenclature, so to say, for the pacing modes. So the basic pacing mode. The most commonly used nomenclature are the first three that are here. The fourth one is also included, but the fifth one, since the invention and then since ICDs became more popular, the fifth one is hardly ever used. So that function is now in the ICD realm. So we have the first being chamber paced, second being chamber sensed, and then the third is the response to sensing. The fourth being the programmability, which is most commonly the R rate modulation. So I'll just give a few examples of what is commonly used. So for instance, the VVI, which would mean the ventricle is the chamber that is paced, the ventricle is the chamber that is sensed, and the response to sensing is inhibition of pacing. So that's just an example. I'll move quickly because of the audience I'm speaking to. It's an audience of mostly my teachers, so and I know that these are basic concepts for most people here. Preoperative evaluation is the history is very important. Now, in particular, after having established an indication from your history and all that, but in particular, you want to find out certain things that will affect the procedure that you're going to do. So has the patient had any prior surgery or radiation in the chest region, shoulder region, that may affect where you are going to carry out your procedure? And then looking back at the contraindication we mentioned, to recognize and treat any active infection, be it a pneumonia, a urinary tract infection, whatever it is, because you don't want to insert a permanent pacemaker in the presence of an active infection. And findings would also focus on these things. Now, the implantation technique, there are various techniques that may be used. First of all, antibiotic prophylaxis is indicated in this procedure. For the transvenous technique, one can either use the cephalic vein cut-down approach, or the axillary approach, or the subclavian vein approach. It's a matter of preference, really, each one having its advantages and disadvantages. The cephalic vein approach is commonly used by some people who would prefer to avoid, because of the risk, especially with the subclavian approach, of the risk of a pneumothorax that many people mention. Some people just prefer to use the cephalic vein approach, which the cephalic vein is easily accessed in the deltopectoral groove. The fat part in the deltopectoral groove is dissected, and the cephalic vein, as shown in the picture there, so the cephalic vein is dissected and cut down, is incised, and the lead is placed into it, and then under fluoroscopy guidance, the lead is then guided into the ventricle and then the atrium. The axillary vein approach is Seldinger technique, so is the subclavian vein approach. So once the veins, the access is gained to the veins, the guide wire is confirmed in the IVC to show that you are actually gone into the veins. Then the introducer is placed and the leads are passed through the introducer under fluoroscopy guidance. And I'll just show the pictures. This is just an illustration. So this is essentially, this is a fluoroscopic image showing what you want to achieve with a dual chamber pacing. The ventricular lead is usually placed first, and then an appropriate position is determined. You check that the R wave is greater, the amplitude of the R wave is greater than 5, and then you confirm the pacing threshold. The lowest pacing threshold is preferable, and a pacing threshold less than 1 is adequate. And then you do the same for the atrial pacing lead, usually placed in the atrial appendage with a J lead, and this, just as shown. After that, the subcutaneous or submuscular flap is created, is created, and then the pulse generator is placed. That's subcutaneous or submuscular plane that is created is usually done by blunt dissection. It's thoroughly irrigated after that, and then you have to ensure adequate hemostasis to prevent complications that may arise, like hematoma formation and all that. So all that is done, it's irrigated, and the pulse generator is connected and placed in that pocket. For an epicardial pacemaker approach, there are various incisions that may be utilized. One of the most common indications for an epicardial pacemaker would be post cardiac surgery in a child. So an inferior stenotomy incision may be used. A subcostal midline abdominal incision may be used, and the other incisions are shown. An anterior left small thoracotomy, called the last incision, may also be used for that procedure. And these are the leads, again, may be the sutured lead or the screwing lead as shown in the picture. This actually just shows in a child, usually the pulse generator will be placed in the abdomen, subrectus. Post-implantation, usually patients continued on antibiotics for 72 hours. Analgesics are given. The pacing stability is established with the rhythm strip, the baseline chest X-ray. You may choose to do a Holter, just to document the changes during certain activities. Now, early complications from the venous access, especially, of course, the percutaneous or the Seldinger techniques for the venous access, may be a pneumothorax, a hemothorax, air embolism, especially when the lead is being introduced. This can go both for the venous cut down technique or the pectineous Seldinga technique. So it is advised that when the lead is being introduced, the patient should temporarily hold their breath, and then you introduce that. That helps to avoid the air embolism. Of course, the pneumothorax and the hemothorax are avoided by the technique of the subclavian or axillary access that is used. But more importantly, that's why the X-ray post-procedure is important, to check for it and deal with it if it's there. There may be lead perforation during the procedure, myocardial perforation. There may be malpositioning or dislodgement, which one will recognize by an acute change in the amplitude of the R wave or the pacing threshold. And this is more common, the malpositioning or the dislodgement is more common with the passive lead than the active lead, which is why with the passive lead, usually the patient's arm is strapped. The left arm is strapped for at least 24 hours post-procedure. Other complications, pocket hematoma, infection, wound dehiscence, pain. And then there are times that one would notice that maybe it suddenly stopped pacing and you're trying to figure out why. One of the reasons may be a loose set of screw where it connects with the pulse generator. Late complications would include infection of the pocket or the lead, pocket erosions, wound breakdown, lead fracture, venous thrombosis, which again is more common in if a transvenous approach was used in a child or a smaller adult, which is the reason why in children they use epicardial. Chronic pain, tricuspid regurgitation over time, left ventricular dysfunction, the migration of the pulse generation, or Twiddler syndrome. Twiddler syndrome is basically from twisting of the pulse generator in the pockets, in the pocket, usually by the patient, so it's more common in elderly people. And then that twisting may lead to either a fracture of the lead or dislodgement of the pacer. So this is no pacemaker symbol. For patients with pacemaker, they may see this sign in various places. It just shows that they are not supposed to enter a place with this sign without having advised the personnel there. So in conclusion, pacemakers are one of the most life-saving devices of modern medicine. A good knowledge of its implantation technique and potential complications, very importantly, is essential so that these complications can be dealt with. And one must always be ready for that, to deal with these complications if the service is going to be provided in an institution. Thank you very much.
Thank you, Dr. Osei Daudu, for the wonderful presentation and doing justice to this topic and keeping well in time. The next presenter is another homeboy, our Chairman Medical Advisory Committee, in the person of Professor Stanley Ugbowo. So he is going to be taking us on the topic pulmonary resections. That's lecture 4. Professor Ugbowo, you have the floor.
Good morning, everybody. I'm going to, because of time, I'm just going to run through this. Okay. Can I have the pointer? So we're going to look at pulmonary resections. You know this. Andreas, maybe you change it for me. Okay. Okay, let me just start. Pulmonary resections, as we know, is I want to take out a disease part of the lung, or indeed the whole of the lung. So how do I go back, actually? Can I go back? Okay. Okay. So you're welcome to UBTH. Welcome to this conference. This is a place where we practice our craft, and it's pulmonary resection seems to be, for us now, one of the main things that we see and we do regularly in this unit. Of course, this is my outline. I'm not going to spend so much time on it. Not working? Is it a battery thing, or is the big button I'm pressing? I'm pressing all the buttons, actually. So anyway, the lungs, as we know it, they're the right and the left lung, okay, and with the various lobes and the segments. Can we go back? Go back one. So we have the right and the left lung with all that, the lobes and segments. Now, these are important when you're going to look at specifics concerning lung resections. Okay. Now, I'm sorry. Now, we're going to look it's important that we look at this and understand some of this anatomy, because pulmonary resections is essentially based on anatomy. And if you get your anatomy right, then your surgery is pretty smooth and plain sailing. Now, if you look at it, okay, maybe I should point to this. It's not. I wanted to use the. No, I wanted to use the laser. The pointer doesn't work. Okay. Anyway, you can look at the hilum. You'll see that if you look at it, you'll see the bronchus and the bronchial artery, and then the arrangement of the pulmonary vessels, the veins coming out of the lungs. Now, this is important because many times when you want to do the surgery, in terms of your approach, anterior or posterior. Sometimes these are important, depending on where the lesion is, depending on fibrosis in the lungs and adhesions that are occurring there. Just change it for me, please. Okay, so again, this slide I just put here so that we can give you a proper distribution of how the hilum looks like. And if you look at it anteriorly, of course, you have where the pericardial impression is. Of course, you know the diaphragmatic and all the rest. You see, depending on your approach, of course, for some, for the cancers, there's a approach is to try to prevent spread as much as possible. So you start with the veins before you go to the arteries, and then the bronchus last. Of course, but all of this is dependent on, again, on the position of the tumor and the expertise of the surgeon who is going. Next slide, please, quickly. Now, go back. Now, if you look at this, now this is the surgeon's view when you, of course, when you are looking at it from the right, okay? I just want to show that sometimes it's a bit challenging if you want to reorientate yourself when you are, okay. Thank you. So, okay, so you can see the proximal end of the right superior pulmonary vein. This has been stapled and cut, so you can see the pulmonary artery as it disposes itself. Now that's important when you depending on what you're doing, whether it's a lobectomy, a bilobectomy, and all the rest. Now, okay, I think I'm going backwards now. Now again, this slide here again just to show how it displays out, and it's important when you are dissecting, and you see, maybe if we have time, we look at some of the peculiarities on them. So what are the indications? We don't have too much time to spend on this, but lung cancer is one of the indications, stage 1, stage 2. But sometimes for stage 3 and some patients who have some peculiar requirements, maybe the patient is having massive hemoptysis and some other things that may necessitate you to want to go and operate that patient. Bronchiectasis again is one of the main indications, of course. Usually you want it limited to the lobe or the lung itself. Destroyed lung syndrome, massive hemoptysis is I'm sure many of us have had to deal with that as a reason for you to really need to go and do surgery, even for patients for which you were concerned whether they were even candidates for surgery in the first place. Of course, then bullous disease, destroyed lungs, and all these other reasons. Now, of course, preoperative preparations is important. You need to look at lung function tests because you don't want to create a respiratory cripple. You want the patient to be able to have a normal life as much as possible afterwards. Because I'm not going to bother with the details. We don't have enough time for that. But bronchoscopy is important for you to be able to delineate where the tumor is. And it's quite important for tumors that are centrally placed. Okay. So, and of course, sometimes we also do that for the double lumen tubes or blockers that you put, just to ascertain good outcome when you're in the surgery. Of course, full blood workup, and then of course it's important to have some measures of invasive monitoring because of the hemodynamic changes that can occur and complications that occur during surgery. And use of double lumen tubes and bronchial blockers is important. But of course, it depends on the expertise of the anesthetist working with you and the ability to control that. Now, the incisions, usual incisions we have are the posterolateral thoracotomy. I didn't write the anterior, but some persons have talked about use of anterior thoracotomy, lateral, strictly posterior thoracotomy. Increasingly, mucosparing thoracotomies, we do that. I do that as a routine now. Of course, the idea is to reduce the mobility of what you have when you have mucus splitting. Now, the VATS and the robotic, actually, video-assisted thoracoscopy surgery has supplanted open surgery in most centers now. And of course, the only we'll talk about contraindications and indications for VATS. Now, robotic is actually robotic assisted VATS, actually. So the standard positioning is usually your lateral decubate position with padding of these areas, and preferably, if we can, put a double lumen tube which will aid your surgery. Okay? I'm going to go from the less to the highest because I don't have too much time. So segmentectomy, first of all, this is just stating how it's done. I know that for many persons now, they don't do segmentectomy, they just do wedge resection. And part of the challenge is because of when you're doing segmentectomy, you want to go through the planes as much as possible. And it can be a challenge. What you can do is to you can ask the anesthetist to inflate the lung, and if you can get around where the bronchus is, the part, you can see if you can clamp it, that keeps it inflated while the rest part of the lung is deflated, and can help in your dissection when you use sharp dissection with diatomy. That's a useful way to go. But of course, the non-anatomic dissections is what a lot of persons use, especially with use of staplers. Okay. And this is just a pictorial depiction of how epical segmentectomy there. Now you look at on the left, or is it right side now? Yeah, you have the wedge resection, so you can use your staplers. And sorry. Sorry, I don't know how I jumped. Okay. I was looking out for, you can use your staple device and you do a staple and then you cut, okay? And this again is another example of a non-anatomic dissection. You can just do that, use your staplers, and then you can cut. For lobectomy, there's no time today in this short lecture for me to talk about the specifics and technicalities of the different lobectomies. But of course, it suffices to know that these are you can do a right upper, right left lower, depending on which part of the lung. Middle lobectomy. Of course, we'll talk about bilobectomy later. The approach for lobectomies and pneumonectomies, as much as possible, is through the fourth or fifth intercostal space, because the hilum is nearly usually fixed. But of course, if you are doing a segmentectomy or a wedge resection, you may choose depending on where the lung is. Although you can technically push it into view and do your resections. So the sequence is usually for tumors is usually vein, artery, and bronchus. But of course, if it's an infected case, maybe it's bullous disease, bronchiectasis, you may start with the artery first. The idea is to prevent loss, especially for a pneumonectomy. We'll talk a little bit about that. Now, you can approach the hilum anteriorly or posteriorly. Some persons like to approach it anteriorly. But don't forget that the approach to the hilum may be difficult if the lung is adherent to the chest wall. And so you may need to do a decortication. Sometimes the challenges in the technicalities is your ability to do a proper decortication. And then if there are challenges with the transverse or oblique fixture being incomplete, you may need to do something about that in dissection to get towards the hilum, so that you can expose it anteriorly or posteriorly to be able to work on the vessels there. So bilobectomy, essentially more the right, of course, usually middle and lower, but sometimes it can be upper and middle bilobectomy. And usually because either the tumor crosses the fissure line or the destruction, there may be an associated destroyed middle lobe, which necessitates you to take it out with the upper or the lower lobe. Of course, in pneumonectomy, I'll just run through quickly on this. Don't have too much time now. Again, like I said before, fifth or fourth intercostal space, because in the end, you're going to be working on the hilum. Okay, I know that in some situations when the lung is contracted, especially in destroyed lung syndrome, you may find out that the fifth intercostal space is very high up, and it's not directly. It may look like a third intercostal space from the approach, but it's important to make sure that you are working directly on the hilum in the end, because that's where most of your dissections and surgery is going to be. Of course, you go through your inspection, look at the lungs, pericardium, and then you look at what you are resecting it for. If it's a tumor, whether there's an associated involvement of the great vessels, the base of the heart, or any other thing that may warrant it to be inoperable. You also want to look at whether you may need to do some chest wall resections along with it. Of course, as much as possible, we use staplers a lot for most of our cases, whether it's for the arteries or the veins. It's also important to know that you may have some complications. You can foresee that, especially where you have empyema subsisting in this patient. So when you do your surgery, you try as much as possible to complete your decortication. Don't leave any infected material within the space. And then, of course, you do some irrigations of the place. We tend to irrigate, and then after we're done, we do a leak test just to make sure that there's no leak. We try as much as possible to do our bronchial suturing flush without stenosis and without leaving a stump. And as much as possible, we do not skeletonize the bronchial stump. Sometimes if we're concerned, we do it without staplers. That's we cut, because there's a double tube in place. You can cut and then look at it, and then you can do your proper suturing. Many times we crush the phrenic nerve, that reduces the space. But you know, when you crush it, the sphenic nerve can recover its function with time. So, but the idea here is to try to balance the chest. We usually close with a chest tube in place but clamped, which we remove within the 48 hours of the surgery. I just want to mention this before I begin to go to some technical points and round up. Sleeve resections. Now, there's a justification for this. As much as possible, when you find out that you want to preserve lung parenchyma and lung function as much as possible, the challenge here is that because of the way the tracheobronchial tree is, if you have proximal tumors obstructing around the carina or around the main stem bronchi, they may just be around there, but the distal point may be free of tumor. So how do you preserve that without unnecessarily taking out good lung that will be useful for this patient going forward? So as much as possible, you want to look at these patients, look at their pulmonary function. Ideally, if you're not able to do the surgery for these patients, what you will end up doing is to do a stent, to put a stent for these patients and send for radiotherapy. But if you can, and you have the expertise, we want to try sleeve resections. It was pioneered incidentally pioneered in 1947 by Price Waters, and then popularized by Mattei, Paulson, and Shaw. And many centers routinely do that for centrally placed tumors for which the distal lung parenchyma seem to be free of tumor. Now, the essence of this is, I just put this just to show how you're trying to bring these points together. You have to do reanastomosis of the vessels, and that's of the distal vessels and of the distal bronchos, bronchi or bronchi that is involved. Okay, so this is just a simple example of one. For instance, there, if you take out, this is the bronchus intermedius. Now, if you have a tumor there and it's just localized there, you want to preserve as much as possible this lung parenchyma. So you do your resection, and then you hike this up into, okay, for instance, like in this case, for instance, you are taking out, you can see the lines of resection there, and you want to preserve this big part of the lung, and you hitch it up there. And same thing here, you take up the upper part, and then this lower part is hitched up there. Again, the same thing here. So the idea about this is to preserve lung function as much as possible. I know there was a time when Professor Fegu was with us where we thought about trying on some patients, but of course we have never really had that opportunity to try. Most of our patients come quite late, and then you just have to do a pneumonectomy or a bilobectomy. Now VATS, it's interesting because I think quite a number of centers have already started doing VATS. At least I hear on our platform we talk about the 3 ports, and then some are even doing the uniportal VATS already. And I think we have some presentations even in this conference on this. Now, the beautiful thing about video assisted, we are trying to start. We presently just have diagnostics for our VATS, or we are not fully functional for resections right at this point. So the big thing about that is that the visualization is very good, and then allows the procedure to be performed in patients who are debilitated or have marginal pulmonary reserve. So it's much better for patients, and you can use it for wedge resection, segmentectomy, lobectomy, and pneumonectomy. the usual challenge for patients here, for surgeons here, is if, for instance, you have challenges with severe adhesions and frozen and chests, especially around the high lungs, that makes dissections hazardous. You know, it has less morbidity and allows quicker recovery and return to normal everyday activities by the patient. Now, the absolute contraindications marked unstable or patient who is in shock, excessive adhesions of literally in the pleural space. If the patient has had prior TAC pleurodesis, that makes it very difficult. Of course, if you have relative contraindications, will be inability to tolerate single lung ventilation, because for that you really do need the lung, that space collapse. Of course, previous thoracotomies. Now, it is relative because it depends on your surgeons and it depends on the expertise of, on your anesthetist and the expertise of the surgeon. Some of these can actually be obviated. People have reported able to do that even with patients with extensive pleural disease, coagulopathy, and prior radiation because of the adhesions. These are the equipment for that. I decided to put this up because it's a workshop, so that we can just look at some of the particular things, equipments that are required, and this is an example of single or uniportal VATs, just one port, and then all your instruments go through it and to do your surgeries, because your camera port and all the other ports, they pass through there to work in the surgery. The good, beautiful thing about this is that the visualization is very good, because I mean you're able to see very clearly magnifications, and you're able to get good dexterity. Because now this is the 3 ports, although some surgeons use 2 ports, some surgeons are known to use 4 ports. Okay, but essentially these are the standard VATs. Of course, this again can be robotic assisted. So in robotic now, I don't have any experience with robotic. Robotic in many centers is the main thing. I think the cost of the machine, the robots, is what's it's affecting a lot of these things. So, and this is just a diagram showing on the left side, you have the surgeon on his console. Within the theater, is looking through there and it's manipulating the instruments. This is the robotic arms that are inserted into the patient. Most of them, I think they are about 4 ports, many of them, 4 ports, and then the surgeon is able to control them from within the theater, or sometimes from even outside the theater space. He's able to, people have reported very good outcomes and very good precision surgery using robotics. Now, post-operative care, usually patient is recovered in the intensive care unit or a step-down unit. Sometimes for some of our patients, especially lobectomy patients, we can send them straight into the ward. But that means, of course, you have to be hands-on in the next 24, 48 hours to ensure that the patient doesn't have a complication. Pain management is very key. As much as possible, we want to, and sometimes we start this by counseling and physiotherapy pre-operatively. We use opioids, we use morphine, and we use intercostal nerve block for some patients. Chest tube management, again, like I said, for pneumonectomy, we put a chest tube, but essentially it's not to drain, it's just to keep and monitor, and then we take it out within 48 hours. For the lobectomies, bilobectomies, we leave the chest tube in place. Once it's no longer draining, usually by 48 hours, we take out the chest tube. We have not needed to put suctions on them for many of the cases. Respiratory therapy and pulmonary hygiene is very important. We quickly get the physiotherapists to be part of the whole process, pre-op and post-op, because we watch out for these important complications. Because bronchopleural fistula from early, it's a big problem if you don't, and which we try to prevent intraoperatively. Pulmonary edema can occur, especially if you use a lot of fluids post-op, especially in pneumonectomy. So we have to watch out for your fluids. Bleeding, residual space, space problems. When you have pleural space infection, that's not a good thing because it can become a cascade of challenges. Respiratory failure is another thing to worry about. I think I'm done. Thank you very much.
Ah, Waalaikumsalam. Escúchame esta. Ya, vámonos.
بنزل page down page up
هيك داون واب هيك رمين
شوية من شوية ترجع للآخر
اب وداون
Okay. Dear esteemed society's member, so we are in the call along with Professor Bukhalil. So whenever you can allow us, because if we need to share the screen, we need permission. All right, excellent, thank you. We are waiting your green light when we can kick off the call. Can you hear us well? Would you please confirm?
Hello, can you hear me?
Yes, we can.
Can I start?
Yes, so yes, Professor Bukhalil, so we can start, they allowed us. So first I would
us?
like to thank the organizer, to thank the society in Nigeria. It's an honor to collaborate together on yearly basis. And today we have Professor Bukhalil on board. Professor Bukhalil, he's the Chief of Division of Cardiothoracic Surgery in St. George Hospital University Medical Center in Beirut, Lebanon, and professor at Balaman Faculty of Medicine in Beirut. So I know, Professor, there's a lot to introduce you. I will provide you all the freedom to kick off the call and take us through your informative session. Thank you and good luck.
Good morning, gentlemen. Thank you, Elias, for your nice comments. Thank you for inviting me to be with you today. Hopefully we can have an interesting lecture together, and maybe we can leave some time at the end for some questions. So I'll go through the process with you. Trying to move the screen. Okay, so I would like to discuss today in the lecture the incidence of permanent pacemaker insertion after SAVR, which is the surgical aortic valve replacement, and the TAVR, the transcatheter AVR, and also discussed a modified surgical aortic valve replacement, which we will call for now the MAVR, just to keep that in mind. And also would like to talk about a new benchmark for TAVRs. PPMI, or the permanent pacemaker insertion, is one of the common complications after SAVR and TAVR. PPMI post-aortic valve replacement decreases survival and increases readmission rates. We know these for a fact. There are early risk factors for PPMI and late risk factors, and we will discuss both because the numbers differ for each. So for early PPMI, the risk factors are age, history of arrhythmias, pre-existing conduction defects, and concomitant bypass surgery or ablation. The risk factors for late PPMI are age, diabetes, and chronic lung disease. Now, what's the incidence of PPMI post-cardiac valvular surgery? This is a paper from JACC in November 2019 by Moskowitz et al. they collected the New York State data for all patients having aortic and mitral valve surgeries over 20 years. And the incidences were for aortic valve replacement, the SAVR at 10 days was 6.1%, as opposed to the TAVR, which is 9.3%. Whereas the PPMI over 2 years was 11% for SAVR and 13% for TAVR. So we can see already that at 2 years, the incidence increases. How about the Observant 2 trial? This is a real-world multiple comparison of TAVRs. And this was published in Circulation in December 2022 by Costa et al. They collected over 2,700 patients from December 2016 to September 2018. This is a multi-center prospective study. So the incidence of permanent pacemaker, we have in hospital, as you notice here, for 5 different valves. And we have the incidence at 1 year again for the 5 different valves. And you can tell from this that the lowest PPMI after a TAVR was 9.6%. This is the lowest. And the highest was 22%. So in real life, the incidence of PPMI post-TAVI or TAVRs is high. So if we put it all together, the incidence at 10 days for the SAVR is 6%. For the TAVR in 2018 was 9%. And in 2022, it remained 9.6%. And at 2 years, for SAVR, it's 11%. And the TAVR around 12.5 to 13%. So the incidence post-SAVR is definitely lower, but we can improve that. So the concerns, why are we concerned with permanent pacemakers? Because there are long-term complications associated with it. If you put a permanent pacemaker after an aortic valve surgery, it increases mortality and increases the incidence of heart failure. It also adds to the cost as well. This is a study done by Glasser et al. They collected around 25,000 patients and they followed them for 20 years. This is a very interesting study. They all had surgical aortic valve replacement and they all needed a permanent pacemaker post-operatively. The mean age was 69 years. What he found out is that the mortality was statistically significantly increased in the pacemaker group compared with the non-pacemaker group. And the risk of heart failure requiring hospitalization was also increased. There was no significant difference in the incidence of endocarditis. So the pacemaker post-op will affect mortality and the risk of heart failure. Their conclusion after the study was that TAVR is increasingly used in younger patients, so future research should investigate how to avoid permanent pacemaker dependency after SAVR and TAVR. Now, around 2016, I would like to share with you now the modified SAVR technique, which will decrease the incidence of PPMI after surgery. Around 2016, we came up with a small modification of the usual technique for surgical AVR. And the idea was to avoid trauma, edema, and inflammation to the conduction system. It's a simple, reproducible, and safe technique. You will see after I present the data, it's something you can do tomorrow morning in your operating room. We all know where the conduction system is. It lies just below the aortic valve. And to be more precise, the commissure between the right and the non-coronary cusps, this is the area we need to avoid. So the whole technique is concentrated on this area. What we do is, I'm sure, or we're talking about the bioprosthesis, we usually put the pledgets below the annulus, but around the conduction system, just in the commissure between the right and the non-coronary cusps, in this area, these three sutures, we put the pledgets on top. Just like I said, a small modification that makes a big difference. We did a pilot study, a double-blinded randomized study over 1 year, and all patients received an isolated AVR, and we presented the data in the ACC meeting in 2019 and the ESC meeting in 2022. And the data were published in the International Journal, Cardiothoracic Surgery, and the European Heart Journal. There were 100 patients in each group. All patients received a tissue valve. The first group underwent the classical technique, where all the pledgeted sutures were below the annulus. And the second group, like I mentioned, just received the classical technique, except for these three sutures at the commissure between the right and non-coronary sinus. These pledges were applied above the annulus, as mentioned. All patients were followed for 2 years, and the groups were matched using the Pearson chi-square test to compare all variables. We had 25 medical and surgical variables. Just to give you an idea of the surgical variables, extreme debridement of leaflets, the valve size, the placement of sutures. These are all important in the surgical technique. The results, we used a binary logistic regression that showed the modified operative technique was the only predictor of the need for permanent pacemaker insertion, and it was very significant. The outcome, the permanent pacemaker insertion rate was 2.17% at 1 month and remained the same at 2 years. So we're already down to 2% from the usual SAVR, which is 6%, and the TAVR 9%. So after publishing our data, we adopted the technique for all our patients. So the next 200 patients, we used the same technique and followed them for 2 years. And what's interesting is that the learning curve is not steep at all, because the incidence of PPMI was 0 at 30 days and only 0.5% at 2 years. So this is a reproducible technique, and it's very easy. Now, you don't have to take my word for it. Is it really reproducible? This is an interesting article from Japan, where Yanagisawa and et al. Used this technique on 83 patients requiring a tissue valve. It's interesting to note that they started using it after TAVR was introduced in their institution. Their incidence of PPMI was 0% at 30 days. So it is really reproducible. Just to sum it up for you again, so the SAVR, at 1 month, it's 6%. The TAVR, it's 9%. The initial modified technique is 2.17%. And later on, after you get used to it, you can get it down to 0%. And at 2 years, the SAVR, you can take it down from 11% to 0.5%. And you can compare that to the lowest number for TAVRs, which is 12%. So this is a significant improvement in PPMI insertion post SAVRs. In conclusion, I don't want to keep you long. I'd like to note that the modified SAVR technique is simple, safe, and reproducible. The incidence of PPMI at 30 days is 0%, and at 2 years, it's 0.5%. The PPMI of 0.5% should be the new benchmark whenever TAVR is considered for intermediate and low-risk patients. And I think this is where we should say also that new ideas are needed to achieve similar rates for TAVR. Our cardiology colleagues need to come up with ideas to decrease also the PPMI post-TAVR. Thank you very much, and I'll open for questions. Can you hear me?
Yes, I can hear you. So I want to confirm from the room in Nigeria if they can hear us. Thank you again, Prof, for this very nice, smooth, objective presentation. So Jitad is telling me there is some questions in the area, but
Sure.
maybe they are waiting because we can hear a lot, some echoes. You can text us if you don't want. Use the chat please tool to text us your questions. Because they were hearing us, Doctor. I was liaising with Muhammad. They were hearing us well.
I hear a lot of echoes. I hope they heard my presentation.
Yeah, they did. But now they are trying to use the mic to ask you. But maybe the audio in the room. Yeah, I'm in contact with Jitato.
Prof, can you hear me?
Yes, we can now.
Thank you for the presentation. Interesting to note that just a simple difference in the technique, just 3 sutures placed differently has made a lot of difference in the patient's outcome. We start trying this, also note our results, and probably we will be able to publish and give you a lot of feedback concerning it. So if anybody has questions in the auditorium? And no questions from this side. Thank you.
Excellent. So I have a questions in the chat.
I did not hear anything.
Yeah. So Professor, so they were asking. So they were asking that the technique is clear, and there is no inquiries on this technique. Maybe questions from the chat. How is the modern design of the contemporary bioprosthesis is influencing on the ppm? So
this is a very good question. Yeah, it's a very good question. But we use the same prosthesis for all the patients. So our incidence of PPMI is not related to the valve used. It's the same valve. It's, well, this is a Medtronic meeting. It's the Medtronic valve. It's a good valve, but it's so the modern prosthesis definitely is better than the old one, but the problem with PPMI is with the technique. It's not the prosthesis, because I presented all this data up to 2022 from New York and from the partner trials, and this is up to 2023, and they were using all the modern prosthesis. There are no old prosthesis in this.
thank you, Professor. Is that another questions? Is the ppm rate is the same with bioprosthesis and the mechanical? Is
yes, and another good question was with the mechanical valve, we already put all the pledges on top. But I think it does not matter what prosthesis you use, as long as around the conduction system, you put the pledgets above the annulus to avoid the inflammation and the edema and all the problems with the conduction system.
Thank you, Professor. It was from the chat. Any other questions from the room? And then we can give you back your time. This way we will be respecting our time frame to present. 30 minutes. Okay. So you have the email and the bio of Professor Bukhalil on Google and with our colleague Mohammed Jidado. So please feel free to email him in case you have any inquiries or for further clarification. Thank you for the trust, and we wish you a successful meeting.
Thank you very much, and hope to see you in person soon.
Thank you. Bye-bye.
No?
Kama wewe na. I'm inside the office now. You know, that's at the office here now. I'm your. Are you wait? I'm upstairs. Upstairs. In the lab. Lab. Okay, I'm coming. I'm coming. Then I'm coming there. Come.
And we publish a paper on this. So if you go online, you can see we had about, I think, 7 of these procedures we've done, which we publish. So what we do is that the anesthetist or a resident will introduce this through the mouth. So through the mouth, then, so we have what's called the anvil, which we are going to put into the stomach end. And then from the stapler, we're going to come through the mouth, get to the pharynx, digitally palpate it since you already opened there. And then you guide the stapler and the person handling it to the right position in the pharynx. Then they bring out the stapler, they open the stapler. So that screw comes out, enters into the anvil, and then they close back, and then just cut, and everything comes out through the mouth. So you have a pharyngeal gastric anastomosis done per oral. So that's one way to use this, and it will save you a lot of time. The stapler, one of the good things about the staplers is that it saves you a lot of time. It takes away an hour and a half of your surgical time away. I think when we did this 10 days ago at Tebutemeta, the total surgery time was for Oringas was about 3.5 hours or so. So it saves a lot of time, saves energy. You can go on to do it. You can go on to book a second case for that operating day. And you won't have the back pain that is associated with people who stay long doing oesophageectomy. Anybody who, when we mention back pain, back and waist pain, you will know that these people have done it before. People who are not smiling, they haven't done that surgery before. But if you've done it before, you will know that it's a big problem. So that saves you a lot of that time. And I usually ask people to do this will shorten your time by an hour and a half. If you decide to use the energy devices, either ligature or the harmonic scalpel. That further takes over another 1 to 1.5 hours. So it doesn't make sense for me, as far as I'm concerned, to do this surgery without having those devices. If you can do it, so there's a balance between cost, increasing cost, and then convenience and the health of the surgeon. So, yes, mobility for the patient and then the health of the surgeon. We must take care of our own health. And then also think about the fact that even though the patient is going to spend more money having this, one, he has the more secure anastomosis, then two, you're able to do a second case, another case for that day, rather than just doing one case and then go on. Then thirdly, you're not going to be abusing analgesics. Any questions so far on the circular staplers? I wish we could really open one and use, but that depends on the LOC. If the chairman will allow us, give us permission, then we will do it. Do you have any questions, please? Is there anybody here who has not seen these staplers before? Everybody has seen, isn't it? Or if people are shy, don't be shy. It's not part of your exams. Eh? All right. You haven't? Okay. So we need to begin to use. This one is called the TA stapler. Okay? It's just sutures. Okay? Doesn't cut. And it's similar to these ones, but you can use for the bronchial stump. Okay? And if you get the vascular reload, which is either white or gray, then you can use for the vessels. There's another kind of stapler. It's called by Coviden, endo-GIA stapler, which is used in lung resections. I think people use, yes. So used for lung resections, and it saves you a lot of time and a lot of problems because you're not going to be having sutures tying and tying and tying. It just applies and clamp and fire, and that's it. The vessel is divided, okay, and stapled in 2 or 3 layers. This guy, you are based where, sir? Lagos. What's your name? I don't know you. Yes, we can. We are waiting for, maybe this will be cheaper for you to buy, sir. How much is the circular stapler that you have? This one here. 28, yes. Okay, that's not so much. So, if the president tells us to use it, we'll use it.
I thought it was for this.
No. We're just demonstrating it now, but for us to be able to open it to you, we need presidential, either the permission of the president or the chairman.
We need financial backup. So the same is applicable to this?
Yes, sir. So we're waiting for him, for the chairman, the LOC, to give us permission. Left to me, when we were planning this, we had discussion with Medtronic, and the plan was to have this LOC to get this, and to have at least 10 reloads. So each person involved in this can fire, especially a resident, can fire or consultant. And it's so easy to do. So easy to do. So for the various centers, let us try to do it. I know that things are expensive, but somehow in Ife, my residents are here. When was the last time we did hands-on anastomosis? I think it was maybe, they haven't seen one, maybe in our 2 or 3 years ago. So occasionally when we have new residents, we say, okay, let's teach you hands-on anastomosis. And you now learn hands-on, but for one patient. But every of our patients in our small community, and people are not reached there. It's not a state capital. They don't call it city. They don't put city at the end of the name. Nothing. I don't know about that, but somehow our patients, the thing is this, sir. What I discovered is that if you tell patients, this is the cost of surgery, including the cost of staplers, from my own experience, they eventually get the money for surgery. And because you must think about your own health. You must think about making these surgeries to be something that the residents can do. And if the surgeries are so long, it becomes very difficult and boring for them and stressful for everybody. Even the anesthetists will be looking for how to postpone your case. But if now you are using staplers and you tell the anesthetists, oh, like in Ifen, if you tell them we are doing osseous replacement today, they are very happy. Why? It gives an opportunity to put in invasive lines. So they're very happy about it. They're very happy because you know that in 3.5 hours you are through with your surgery.
Still working on the modalities to make this practical. Can we switch over to the cardiac? Because
any questions, first of all? You should not be silent. The resident, it's time for you to ask questions. Because a time will come where we will be the ones to ask you questions. So ask now, or otherwise forever hold your peace. Those who are online, if you have questions, you can also ask if there are any questions. Or comments. You may have been using these staplers, you may want to share your experience with it. So if there are any...
Same size of linear stapler.
Yes. In fact, we won't prefer, you use the same 80 mm for them, but for the anastomosis, a 60 mm is better. Or we use the 80 mm and not use the whole length of it. So use 40 mm out of it for the staple.
Thank you, sir. Thank you, sir. So essentially, how the way you do this anastomosis, it means the pins are buried in for this linear staple. So if I understand, you have to align it properly. One of the responsibilities is to align the board properly, straight on this reload on both ends, so that when you clip it, there will be no rumpling and none will be squeezed. So we close both ends. Thank you, sir.
Yes. Because we must have questions from Abuja. That's the seat of the government. Are you going to sponsor the opening of these things?
I sponsor myself to this place. Thank you very much for the explanations and the teaching. These circular staplers, what's the age limit for it to go through the mouth? I think the last case you publicized, you didn't use this. You used the linear for the esophagus. Yeah. So, and I think it was a child. So I guess this couldn't go through.
There's no age limit at all for the circular staple. That is if it's a pharyngeal anastomosis you want to do. So I usually reserve this circular stapler for pharyngeal anastomosis, high anastomosis, yes. Because it's so easy to just pass through the mouth. And there are different sizes. These sizes that are here are sizes for general surgery, where they want to anastomose the colon or the colorectal anastomosis. That's what you have. I've never used a 28 mm even when for a circular stapler. You have 25 thereabout for adults, 23, 21 for children. But this is 31, definitely not esophageal, and this one also too. Okay. For what? Okay, in the neck. Okay, maybe you're not here when we talked about it. The issue with the circular staplers, when I first started using staplers, I was using circular staplers for cervical anastomosis. Until I started having a few children who came down with anastomotic stricture. With the linear cutter, you have a much wider anastomosis. This one, let's say it's a 25 mm, a stapler for an adult. That's 25 mm. But you are using a 60 mm or maybe part of it 40 mm. That's much longer than a 25 mm. So you hardly, in fact, we've not had anastomotic stricture using this. Yes, Dr. Akiri.
So the tip of the bowel, so where you make the stab on the bowel from the tip, how many millimeters? No, I think, sir. I don't think you understand clearly my question. Let me explain. Assuming this is the edge of the free bowel you want to understand. And then, thank you, sir. I think what I mean is this. This is the tip of the bowel. We want to put our linear. You said we'll make a stab wound and put it here, and make another stab wound and let it come out from here.
Okay. So let's say, just say, okay. So let's say this is the esophagus. I hope we're all here. So this is the esophagus here. And let's say this is the stomach. We've already mobilized the stomach and brought the neck. Or colon, whichever. This end will have been stapled off. This end is completely, when you are, so what we do is this. So let's say you are doing a Coringas procedure. You've mobilized the stomach already. You've done mediastinal dissection. You've opened the neck. You've mobilized the cervical esophagus. The hand of the surgeon in the neck and the other surgeon in the abdomen have gone round circumferentially. They've confirmed that the esophagus is now freely dissected. Good. So to be able to now take down that esophagus, what we're going to do is that we're going to put in, number one, let's say this is that esophagus, okay, and it's going down to the mediastinum, okay, here. So we're going to put in two stay sutures, one suture on this end, one suture on this other end. Okay, so you have a stay suture here and here. I hope it's clear. Then we are going to now put in the linear cutter here. The linear cutter is here. Linear cutter cuts through this. So it seals this at both ends and divides in between. The stay sutures we have put at the distal end will now pull up and now get the nasogastric tube, a good new nasogastric tube, and suture the nasogastric tube to this distal end. So let's say this is not the distal end, proximal end. So we're going to suture it here. We're in the neck is open. So once we suture it here, the abdominal surgeon will now pull, guide. He will now pull the stomach. As he's pulling the stomach in the abdomen, the esophagus is going to follow it, isn't it? You already divided it, along with the nasogastric tube. So once you get the nasogastric tube to the abdomen, you now detach it from this. So now you have everything in the mediastinum. When you are now going to pull up the stomach, you already have the nasogastric tube in the mediastinum. So you just attach this to the tubularized stomach, and that is nasogastric tube, and then you push while the other person just gets guided on. Hope it's clear. Yes.
Surface of the you attach it on, or you put it
No, on the surface. Because inside it's already stapled. This end is stapled and sealed. This end is stapled, so it's on the surface. You just put on the tape. So now you have a sealed cervical esophagus. The distal end is sealed, taking it to the abdomen. So let's say now this is the stomach with the esophagus attached to it. You pull it out, you're now in the abdomen. So you're not going to tubularize this stomach. Once again, I wish the LOC will provide. So you tubularize the stomach, and you're going to divide this whole portion. So that's esophagus is out completely. Yes, part of the fundus. Correct. So the remaining part of the stomach, part of the greater curvature, and this tube that you have now created, you're not going to now suture. You know it's sealed because you stapled it. So you're not going to suture this gastric tube, which you had previously introduced through the neck, in the spine, and suture it on the surface. And then while the person in the neck is pulling, you are guiding from the abdomen, go through the mediastinum until it comes out. So once it comes out in the neck, this end is sealed. The esophageal end is sealed. So you have two sealed ends. So because you have two sealed ends, you can now have the stomach. So this is your, let's say this is your esophagus. This is the stomach you have brought up. This is the lesser curvature. You are now going to bring it and align them side by side. Anesthetics is going to withdraw the NG tube you had put in before, which helps you to localize, to withdraw it to the pharynx. So you now have these two lines side by side. You ensure that you don't do your anastomosis along the stapled line we used to create the gastric tube. So you line them up. Get whatever size of stapler you have, either 60 or 80 mm. So you're able to gauge how many cm you want your anastomosis to be. And then, let's say you want a 40 mm, it's a little child. So you make your cut here, a counter incision on the gastric end at the same level. You put one end of the stapler here, the other end of the stapler, and then you're going to put them together. Yes, a cut just on the anterior surface until you get to the only until you get to the mucosa. Yes. You stab, yes. This way, going this way. Going this way. Yes. Going this way. That one is going. So it's going yes. Two ends of the staplers are going to go like this. Correct. So it's a functional end to end. It's actually a side to side. Yes. You understand? Residents don't understand. We don't understand. We can't leave them. Yeah, I understand the distal pouch. Wait, no, distal pouch. It's just a small portion there. There's nothing When you say dumping, it's not about dumping things. It's different from what you are talking about. So, we're saying not about dumping syndrome, just about then. And there's no reason why anybody should not be there. Yes. 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 No, side by side. Correct. 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 Same side. Esophagus and stomach. So you have your entry which you are open, just or you have the T8 staplers and the T8 stapler you can use to staple that's where you do it. There's nothing to be afraid of. So once you've done the GI anastomosis with the linear cutter, then you get the anesthetists to advance the esophageal tube from the pharynx under vision, because now with your opening, you are going to be able to see your anastomosis and the NG tube. So they pass the NG tube, you guide it until it gets to the stomach, not just the stomach, it gets to the pylorus. I usually ensure it gets to the pylorus. And the technique we usually use, like we said, for the gastric drainage is a pyromyotomy rather than a pyroplasty. Yes, that's the most.
Sincerely benefit from its practical demonstrations, please.
Chairman, sir. Okay, sir. Chairman has given us his word. Thank you, sir. Chairman, can you ask these are your statements.
Whichever, whether it's this one, take one, or this one, without
And then we'll also appreciate last for donating with the sutures. Let's clap for last. at surgery. Just know that you are not going to be, you may not win the case. Yes. Yeah, go ahead. Mohammed, Mohammed, maybe we can have a
No. Totally okay. You are supposed to be actively doing actively watching. Easy action. So we're going to, I think we're almost through. Just that section. So since we're going to do an aortic valve replacement, so we need to, well, we'll see how the people will do it. This is the coronary artery. It's a big part. So this, can we have an aortic valve here? And then where are the switches? It's a mitral valve. It's a biologic valve. We can actually do both in this. We are going to do a mitral valve replacement and aortic valve. So we have a mechanical aortic valve, and then we have a tissue mitral valve. Tissue valve. So
Okay.
we're going to do both. We have the mechanical aortic valve.
think if we want to do, where's Mohammed? It's not here. People who are online, how are they going to join in? But there's no point using this. Oh, I see. All right, so we're going to start this workshop in a few seconds. We need somebody else to bring out another heart. Dr. Shitemi, are you doing the heart transplant? So, yeah, so the thing is this, with them, they have a big denominator on top. This is the heart. Yes, can get that. This is actually the denominator. This one, yeah. Yes. That's it. But that's it's smaller than the other one. Okay. Well, do you have a lamp? That's why I left it. Yes. But most of the ground we have there, what do they say? So this is for we have the and but they we've already thanked Lasso for donating the sutures for this workshop, and we've all clapped. So we're expecting. So I think what remains for Lasso to do is to pass those staplers. Yes. Body, are you being ministered to already? You made arrangements for it. Okay, you have the video. It's a phone call. But your staplers. Save them. We've done all the theoretical work. Okay, you heard so, how many residents are here?
Do you prepare for this? Because this one can be tight.
How many residents are here? One, two. I see your hands up.
You have to wait.
One resident in the resident. One, two. Any resident here? 3, 4, 5, 7, 8, 9. So we have 9 residents here. And of those 9 residents, how many are in centers that are doing cardiac surgery within 1, 2, 3? So why I asked that is for those 3 senior registrars to be the people on the site, the resident. Then we'll have Shitemi, Alioke, and Akiriki. What are you doing? Have this table. This table is ready for what you have. So, there's no resident here. Except to promise that they will have to throw you outside. All right, so now we have okay, please bring them. So needle holder, scissors. Get them into Mr. Sam.
Aorta. This is the pulmonary artery here. Wait. This one here is the pulmonary artery. This is not the. This is the aorta. So what you do is, so this is done in real, especially for women. I'm not a veterinary doctor. This is the. That's inside. What do you mean shine light inside? So give me that. So this is. No, I'm not even opening. If you look at this here, and that is usually posterior in the, yes, it's usually posterior in the human. Then adjacent to it, somewhere here is the right. It's trying to say that the orientation should be like this. So that when you want to do your oblique, you do like this. Now when you are going like this, you are going far away from the head here and coming down towards the commissure between the left coronary sinus and the yes. Yes. Is it? No, that's longitudinal you are doing. So something like this. And then this way. Yes. So it's not straight up. And then something like this. You can see now that the valve is coming to view. So again,
open up the aorta somewhere here. So when we open up the aorta, yeah, we need the benefit of that light, please. So, yeah, thank you. So, see, you have the cups, the aortic cups. Look at this. This is the left coronary cups, and this will be the right. This will be the right here. So you have this septum. This septal group, and so this is the septal group. So, and this is the one that has this is the one with the non-coronary cups. And they said the connecting boundary is between the right and left coronary cups, isn't it? So if you look at it, so it means we should be talking about, can you see it? Okay. Look at one of the aortic leaflet. No, just look at just look into it. So no, just raise this up there. This is one of the leaflet. This is one of the leaflet here. And then this is the third leaflet. So this one that is on the septum is the non-coronary. So if I understand this orientation properly, it seems as if this is actually the left and this is the right. So we said the boundaries between the non and the right. So the boundary is somewhere here. So when you put your finger here, where I call the non-coronary, you will see like a shelf here. Hmm? Yeah. Classically, you don't see that on that of a human. When you see this kind of shelf in a human heart, it means there will be LVOT obstruction. In patients who have hypertrophic cardiomyopathy, those are the ones you can see this tip. But when you look at that of human, you can actually tell where the septum is. Hmm? So essentially, we aim to put our stitch. Our stitch will follow this margin. Hmm? This margin. Hmm? So if you go back and check on the anatomy of the aorta, you see this in the angle between the left and the right cups, isn't it? It's high up. This one looks a little low. Then this one is somewhere here. So that's why if you check on the anatomy, they'll tell you that the aortic valve is not a perfect circumference. It's more like oblique. See, if you look at the anatomy properly, again, you look at it, see, when you compare here to where this and to where this one is, there's one somewhere here. You see that it's not like horizontal, it's a little bit up. So two things are involved. It depends on the surgeon. If the patient has aortic stenosis, the first thing you do in the aortic valve after exposing like this, you trim off all the valve. You trim off this valve, you take it off, you cut it off, and then if there are calcification, you calcify all this area. What most surgeons will do once they open it, this is the part with the cardiopulmonary bypass. They stick in a gauze here so that no calcium will fall in. Only problem is corona and this vessel. I can't see the corona.
UBTH. This speakers from Medtronic or from UBTH. Okay. And then one more here. Okay, there's nothing here. Just wondering the best way to keep this open. Okay, let's put one here and one there. Yeah. This is your switch complete. To be able to retract, you want it as high as possible. If you take it too low down, you won't get good retraction. You can see when I put it like this, it opens out. Something just close to the edge. Okay. Bring it across like this. Good. Perfect. Okay. We need, this isn't very effective. Yeah, let's have something hang it. Yes. Because it's not live, you have to do a bit more to expose and keep it exposed. So one here, one here. No, okay. Just take everything. Look, we have plenty of this. Use the tool. Think very hard. Or these things. Which ones would I? Every one would I not use? So look at the angle of your hand. See, your body is flexible. You can move. So you don't need to be stuck in one direction. So watching, no. No, too far from the edge. I want you to come in. No, look. That's it. Come in here, come out here. So let me see you orient yourself. Okay, look at how you orient. Yeah, look at showing. No. Are you going to turn the patient? Yes. So I'm looking at your hand. You will never hold like that. Your wrist is flexible. Or change to backhand. Yes. Just always make a practice motion and see whatever is going to be easy, whichever movement will be easier. Okay? Nice, better. Bring it through. Have some weight on it. Ah, too much. But just drop it. Let's see. Mm-hmm. Let's just see how it lies best. It's getting better. Okay, lovely. So let's identify. So let's assume we saw the commission, we saw the honorary here. Where did the light there? Okay. So one. Okay. Here. Okay. So let's try and orient ourselves. So that has to be right, left, and the non-honorary goes the mitral, goes the LA. Okay, which means this is the surgeon's position. So this is how it would be. You normally see the right to your right, the left away from you, and the non-honorary down towards you. So when you first start, the main thing is the exposure. We've assumed we've done the autotomy, and we've now got it stabilized. If you can't see, you can't do anything at all. So the next step would be to excise the valve, and then size. We don't have any sizes here. First of all, which valve are we using? We have it here. So we make sure that the valve matches what we're trying to do. What size is this? Put your finger in. What size do you think you're doing? Yes. This is a 21, 23. This one. 25. This is an aortic 25. Might be able to squeeze. Put your finger in. Tell me what size you think. Yeah, so this one, what size do you think? 23 at the most. Okay, so with that in mind, if this is sizing a finger, so finger is just about going in. I'll say at the most 23. So if I had a 25 and I put it in a 23, what options would I have? How could I get the 25 round into a size 23? Ideally, I should have the sizes available, 19, 21, 23. But if you find that the size is smaller than what you have, what options are available? Just like here now, size is 23. This is 25. 25 will not go in 23.